Hi.
Hi, Jess. How are you?
Good. How are you?
I'm fine. I'm so excited that we have people already on and looking forward to this.
I know this is great. I'm like
Yeah. How was
trying
your
to.
day?
Mine was great.
Yeah.
I saw patients today, using telemedicine. So
Yeah.
yeah,
Yeah.
pretty
Good.
good.
Well, we're so happy that we're here. I'm Dr. Natalie Sekleniak, and I'm with my partner, Dr. Jessica Mann. Um,
Hi.
I know that a lot of you guys have been signing in during our break and doing all this telemedicine stuff and missing all of our patients and all of you. We started these Instagram live sessions eager to educate patients, talk to them, tell them what they need to hear, and people have been enjoying them. So we're really happy to keep doing them. Um,
Yes.
yeah, right. And
It's
this
very
week,
nice. It's very nice to be able
yeah,
to connect this way and to keep educating patients. So one of the things I found, doing all this teleconferencing that is able that we can educate people. And so this is a
yeah,
great tool. So I'm excited that IRMS is doing this
yeah,
weekly now. So
yeah.
it's been now how many weeks? Like 4 weeks, I think.
Oh, it's been so many weeks,
Yeah,
Jess. I mean, we're now, I think we're allowed to talk in months, which is
right.
unfortunate, but I
That's
think we're
true.
on 2 months.
Right, right.
Yeah. And so, yeah, to all of our patients out there are listening, and we hope our friends are signed in too. Our topic today applies to all kinds of people, whether you're trying to get pregnant or not. But we miss you. We're happy to connect with you this way. We hope that you're doing well during this crazy time. We miss each other and seeing each other in the office every day. We miss seeing all of you. This has been rough. We hope you're all safe, and we are really happy to say though, Jess, you were in the office today. We're back, right? You want
Yes,
to
we are back.
catch everybody up a little bit on what we're doing now? Thank goodness.
Yes, so this is actually very exciting. And as you guys will know, that when you come to the office, you're gonna be safe. We've instituted a lot of protocols to keep our patients safe, our staff safe. And so there's temperature screening. Everybody has to wear a mask. We ask you to wash your hands. You'll see us washing our hands often. And it is all, in the name of safety. But we want to take care of you. We want to take care of our patients and help you achieve your dreams. So
Yeah.
but we're
Yeah.
here. It's exciting. It's just
Yeah.
it's different. It's our new normal. So
Yeah,
it'll be fun.
exactly. It's a new normal, probably how we're going to have to do things for quite some time. But we've all of the doctors have rotated in and been in the office for a full day of seeing patients, doing ultrasounds and saline sonograms and exams and things we need to do. And we feel really good about it when we're there. Everybody's happy to see each other. Everybody's
Yes.
smiling behind the mask, and we're giving air hugs.
Right,
But
right.
it feels like a safe environment. It's quiet, it's controlled. There's a lot of new protections at the hospital and lots of plexiglass and things we all have to get used to. But with that, and with the staggering in of patients sort of one at a time and not having too many people in the same space, it feels really good. Everyone's been very comfortable, and we're thrilled that we're getting back to business and getting
Yes.
people cycling.
Yes, yes, definitely.
So, Jess, let's talk about PCOS. So, Dr. Mann, introduce PCOS for us because it's a really complicated topic. It actually is a
Yes.
pretty tough clinical diagnosis. This is not the kind of thing where you send off a lab and you check a box and it comes back yes or no that somebody has PCOS. It's actually something you need a lot of experience to diagnose well. So tell us about that.
Yes, and so I think sometimes, even the name itself can be so scary and overwhelming. PCOS, or polycystic ovarian syndrome, or other people call it PCOS. You've heard of those terms. And it just sounds like, it sounds so scary. Like, what is this? It's basically a disorder that can cause irregular cycles, can present with patients' inability to ovulate. And it's actually a misnomer. This is what I tell my patients all the time, like it just sounds like such a bad thing. Like, I have cysts. You hear people telling you the stories that you have cysts, but it's not. It's basically a condition that is assessed usually by, like when I said, irregular periods. Also, there is a way in which you can identify the ovary. So the ovary has a specific appearance, like the polycystic ovarian morphology that we talk about, but it's not really cysts. They're actually small, like follicles
Yeah.
that we have.
Yeah.
But there's
And
just
I like
an
that.
abundance of
I
them.
like that pearl necklace sign that we talked about, all those little follicles at the edge, the periphery of the ovary, which
Right.
sometimes you see, but a lot of people with PCOS don't have ovaries that look like that. So again,
Exactly.
it's part of this. Some people say, what do you mean? I've had ultrasounds before. Everybody told me everything was fine. It's like, it could look fine, but
Right.
you can still have PCOS, right?
Right, exactly. So, and that's where, we as a reproductive endocrinologists can look at an ovary and can tell you, well, this is in fact that, PCO ovary, ovary looking, but patients go to an ultrasound facility and they may be told, oh, your ovary looks fine. Meanwhile, we look at the report and it's like, yeah, the ovary is large. There are multiple follicles.
Yeah.
And so that matters. So it's
Yeah.
not just,
Yeah.
that
And
pearl necklace, like you said.
right. And typical of most of the difficulty with medicine is there isn't one thing that gives people a diagnosis, right? So it's this constellation of symptoms and they're really variable, right? So we
Right.
see patients who have lots of symptoms, including that they're overweight and they have excess hair growth that really bothers them, or maybe they're even losing hair from their scalp, and, acne and other symptoms and irregular periods. And
Right.
then we have other people who walk in and they are extremely lean and they don't have any of those symptoms. No problems with their
Right.
skin, no problems with hair growth, but very irregular periods. And their PCOS severity could be much worse than somebody that has very few symptoms, right?
Exactly. Yes. And so that's important to note because I tell patients, up to 20% of the patients with PCOS are lean. They just, you have this proportion of patients that would never know because they don't have the features of like, excess acne or, excess hair growth. So they look like fine and maybe
Right.
their periods are prolonged. And some of them, like you said, have just very irregular periods.
Yeah.
So it's a constellation of symptoms, and it's a diagnosis of exclusion
Yes.
most of all, so that we say we have to look at other reasons why a patient's periods are irregular. So we rule out thyroid conditions, we rule out other endocrine disorders like androgen, conditions, secreting androgens, and then you're left with, if it's in neither of those and you meet the criteria, then you have polycystic ovarian syndrome.
Yeah, yeah,
Mhm.
exactly. So that's exactly it. It really is a diagnosis of exclusion. And, we typically do things, we check for other reasons why you guys might have irregular cycles. Is it thyroid dysfunction, or could there be a high prolactin level, or other things? And once those other things are ruled out, then it's usually PCOS. I mean, we will tell you PCOS is very, very common.
Right.
What do you think, Dr. Mann? 10%
Yeah,
maybe
it's
have
about
it?
like,
Mhm.
10% is actually the most common endocrine disorder of like in the reproductive women age,
Yeah,
so like it
yeah,
is very common.
yeah,
So, but and with that comes it affects not just the menstrual periods, but affects skin disorders like we talked about, acne. It
yeah.
affects, the cardiovascular system, like patients are at higher risk of developing diabetes in the long term.
Yes, yes.
Um, and so, and not everybody, like you mentioned, has a weight problem, but,
Right.
those patients that are, obese, then there's significant changes and improvements in their profiles of all
Yeah.
these levels by losing weight. And
Yeah. So
only
I
like
think,
sometimes 5% weight loss can help.
yeah. So I think, now, like, let's talk a little bit about, we talked about how complex this condition is and people have varying presentations, but let's talk about what they can do about it. So the first thing is, 'cause there's so much to cover in this half an hour. So I'm thinking about continuing to move on.
Well, you know what? Actually, Dr. Chen, I see her there. She has a great question. It's like,
Yeah.
how can people with PCOS lose the weight, and what's the best diet? And
Yeah.
that's actually, it's important, but it's true, right? Patients with PCOS exercise. And I tell patients because they get so discouraged. Like I tell you, go exercise. And they're like, well, I don't lose weight. How come I do this? And my partner does the same thing and they lose weight and I don't. Well, for women with PCOS, it's harder. Like I tell you, don't get frustrated. You have to work extra hard. What
Right.
about diet? I mean,
Right.
try to avoid carbohydrates, so there's definitely a lot that patients can do with that.
Hmm. Yeah. So the first thing I think people should know is, I think it's an empowering thing to know that with PCOS, if you have the opportunity to lose weight, to change your metabolism and improve your PCOS and actually make things much better, that's something you're in control of and you can do. And we know it's hard, but yeah, diet and exercise. There are nutritionists who specialize in nutritional counseling and diets that they can write up for you specific for PCOS. So as Dr. Mann mentioned, low carb diets, but there's even more to it. One of our good friends, Allison Tibble, is a fantastic nutritionist, and we refer people to her. There's the Integrative Medicine Center through St. Barnabas, and they have a specific program for PCOS for nutritional counseling and exercise. But the root of PCOS, right, which is something that was only discovered in the late 90s, is insulin resistance. And
Right.
excess weight also
Hmm.
causes insulin resistance. So there's a little bit
Exactly.
of this vicious cycle that, with PCOS, it is really easy to gain and really tough to lose. But losing weight, and surprisingly, as little as a 5% loss in weight, can actually change the way your body works so much so that you could resume regular cycles again. So there's a really big motivating reason to try to take some weight off if that's something that you can do that could make things
Exactly.
work better.
Yes,
Yeah, yeah.
exactly. Yeah.
Yeah,
Hmm.
so weight loss definitely is a big one. And the exercise piece is interesting. Clearly continuing to exercise to increase your metabolic rate, right? Because you just can't eat too few calories. That's not going
Right,
to do it.
exactly.
So those things together are big. But getting back to that insulin resistance, tell Dr. Mann, tell us what you usually do with your patients as far as testing for glucose and insulin and thinking about that side of it.
Yes. So, in general, we're gonna check like your basic metabolic panel, and all the patients that have PCOS, we usually give them a 2-hour glucose tolerance test. So this is
Mhm.
to challenge them and to see if there's any evidence of insulin resistant or like diabetes.
Yeah,
Sometimes we have patients that we find diabetes.
right.
They didn't even know. But another aspect of PCOS that is important to notice, people sometimes think like, is this a gene? Did I inherit it from my family? And while there isn't a specific gene that can like tell you have PCOS or not, we talked about is a constellation of the disorders. There is a genetic predisposition. It runs like in the family. So somebody else in your family might have had it, and so it's important that when we talk to patients, we gather a good history from them.
Yeah, yeah.
Hmm.
So, we definitely, one of the things you think about is getting to that ideal body weight and exercise, and monitoring your cycles. But for general health concerns, and then of course we want to talk about the fertility aspect of this. You don't want to go through life with very few periods, because that means your estrogen levels are very low. The lack of
Yes.
ovulation means you're not creating estrogen, right, for patients, and that can impact your heart health. It can impact your bones and really
Right.
cause problems. Besides, you can feel really terrible, right, Jess?
Yeah. Yeah.
The lack
And
of concentration and inability to sleep. So you definitely have to come see us if you're getting
yes.
very few periods, just for general health reasons. We need to give you hormone replacement to stay healthy.
Yes, and that's actually, I'm glad that you brought that up, because I've had some patients that come in and tell me, I haven't had a period. I just get them twice in a year, and
Yeah,
like nothing's been done about it. And I said, well,
yeah,
that's not good
yeah.
either for your uterus. Like
Right,
your uterus
right.
sees these levels of estrogen, and that increases your risk of endometrial hyperplasia, which is like, not to sound too like technical, but it's like a condition in the spectrum of like, it could lead to something like endometrial cancer.
Yeah,
And when
yeah,
you go on for a long time without a period, and on top of that you add the obesity factor, definitely at risk. I mean, unfortunately, I've had young patients with PCOS that I've diagnosed endometrial cancer. It's
yeah.
sad. I mean,
Right,
not commonly, of course, but this is
right,
the things that you want to make sure that you stress to our patients, that
right.
you can't just go on without periods. So
Right. Yeah,
please, like address that with your
yeah.
doctor, and we
Yeah.
can help you.
And, I see a lot of teens that come in with their mom and they have, regular cycles, and we diagnose them with PCOS. And I say the same thing you say. It's polycystic ovarian syndrome. It sounds so scary. I'm like, listen, this is not a bad thing to have, because this is so manageable. And we go through everything, the weight management and hormone replacement if it's needed, checking insulin and glucose levels, and getting an insulin sensitizer on board if it's necessary, a medication to help regulate those levels if they're abnormal, which can also bring on regular cycles. So,
Correct.
you start at the root and kind of check everything and make sure you're getting the estrogen you need.
Right.
But then it brings us also to, excuse me, the fertility side of things. So tell
Right.
us a little bit about that, because of
Yes.
course we see patients all day long, all week long with this who are trying to get pregnant, and their lack of ovulation or irregular ovulation just makes it incredibly frustrating.
Yes. So
Yeah.
I usually explain this to them, you know, it's like once a month you're supposed to release one egg. And this is because of the way your brain talks to your ovaries. And there are signaling pathways that allow for this to happen once a month. And in patients with PCOS, this pathway just isn't working okay. And so because of that, you know, these patients don't ovulate. And if you
Yeah.
don't ovulate, there is no egg. And without an egg, there is no baby. And so, you know, with that, there are medications we can give our patients that will help with just that conversation between your brain and your ovaries so that we can get that to
Yeah.
happen,
Yeah.
and make you ovulate. So, you know, and we start usually with ovulation induction agents as our first line of treatment, provided that everything else has been ruled out and every other aspects like, you know, the male factor and the tubes are fine, then we can give somebody an agent, an ovulation induction agent.
Yeah. So we
Mm-hmm.
use, I mean, we use a lot of Clomid as a drug that a lot of people have heard about, and that's a great medication to just increase that stimulation from the brain and bring the estrogen levels up in the ovary to kind of normalize the imbalance that's been created there because of the PCOS, right? The root of
Right.
the PCOS is then you get a little bit too much testosterone, not enough estrogen. So these fertility drugs normalize that balance and encourage an egg to grow.
Right.
And some people, if you go out there and you have tried Clomid with your general gynecologist and it hasn't made you ovulate or given you a resulting period after you take it, you can also try letrozole, right? Do you
Right. So
use it too,
letrozole
Dr.
is
Mann?
now, you're
Yeah.
right. Yeah. Letrozole is now like first line. There's some recent studies that have shown improved pregnancy rates, but both letrozole, Clomid has been around for the longest time. So, you
Yeah.
know, we have it.
Yeah.
It's been around for the longest time, safety profile with both, you know, but letrozole, some patients don't respond to one or the other. So, you know,
Yeah. Yeah.
definitely, you know, and I think the Clomid probably has a slightly higher risk of like thinning of the endometrium, right? So
Right.
that one, as
Right.
opposed to
Right.
letrozole, not so much.
But it's manageable, right? We give them a little
Exactly.
extras. And
Yeah.
yeah, one of the things we want to emphasize is the safety. Like you said, Clomid's been around since 1957, used for fertility since 1961. So there's a lot of really good long-term follow-up, and we think it's safe for patients, it's safe for babies. So we have a lot of success. That's one of our
Yes.
messages, is that
Right.
PCOS is so manageable in so many patients, where it could be relatively mild and a little bit of Clomid just fixes the situation. We monitor you, you're
Yeah.
releasing an egg on time, and people do really well. There are
Yeah.
patients that have tougher situations where Clomid may not be enough, right? And
Yes. And
we
so
move on to
sometimes
other things.
other
Yeah.
things, or you could do coadjuvant, like, you know, sometimes you can use also metformin at the same time to
Yep.
improve their response.
Yep.
You know, I actually, now that we talk about like the medications, had a patient just recently ask me also, well, what about multiples? And I say to
Yes.
them, yeah, there's a slightly increased risk of multiples with, you know, Clomid or letrozole. And with that, usually we monitor you, so we know that, you know, if patients have a high risk of multiples, like we have like 5 follicles that are nice and somebody's
Yeah.
in their 20s, we may say, you know, but this may not be an ideal cycle for you. Maybe
Right.
we
Right.
have to cut your dose.
Right. And, you know, I see some questions coming in. Obviously, PCOS is so different for every patient. So it really means you have to work with your reproductive endocrinologist to figure out from like step one, what's the safest way to go and the simplest way to start that could work for you. Some people, a lot of people have success with Clomid and letrozole. If they don't, there are the things that we move to. And it really depends on a lot of things. It depends on your response to those medications and how high would your multiple rate be. We don't want you to release too many eggs.
Yes.
Dr. Mann had mentioned in the beginning, which I think is a very interesting point. PCOS is actually a misnomer. And there have been, to the extent, we talk about it all the time. And
Right.
there's even an article in the Fertility and Sterility Journal, which is like our main journal that we read all the time, a few years ago, with the suggestion that we change the name to polyfollicular
Well,
ovarian
that's good. That's
syndrome,
good, because
right?
we actually started in one of these Facebook groups that I'm part of too. We started like, oh, let's do a petition because
Yes.
we really should change it. And I'm
Yeah.
like, I'm all for it too, because
Yeah.
it just sounds scarier. You know, it's interesting that this syndrome has been around for so long, as
Yeah.
it's described, but this was before the advent of ultrasound too.
Right. And
And
so,
so
yeah, so the thing is, people don't have cysts, right? If someone can have an ovarian cyst that brings them to the ER, this is not a situation where you have cysts. You have a lot of follicles, which are
Right.
little immature eggs in there that are ready to go.
Yes.
And they just need the right hormone. They need to be bathed in the right hormone ratio to
Right.
get them to grow and mature. So one of the things we have to be careful about when we move on from Clomid is the sort of more potent medications can get a few of those eggs to grow at the same time. And we
Yes.
really want to be careful that we don't create multiple
Multiples.
gestations that are
Right. Right.
complicated. So
Yes.
some people do find their way to IVF depending on how they do with these other techniques where we do a single embryo transfer. And it's a fantastic technique for somebody with PCOS because they're able to make lots of eggs and embryos. And then
Right.
we can screen through the group and transfer just one embryo with very high success rates. So lots of options for fertility and I would say just a lot of success in general with this diagnosis. Wouldn't you say?
Yes, I
Yeah.
agree. And I think
Yeah.
somebody had asked that question that I saw before, like, does it mean that because I have
Yeah.
PCOS, do I have to do IVF? Like, not necessarily. You know, obviously, if there are other issues, you have PCOS, and in addition to that, you have tubal factor, and you
Right.
might need to do IVF, then that's a different story. But it doesn't mean you have to do IVF necessarily.
Right.
One thing before I forget, when we were talking about, you know, like the drugs too, they are side effects. And that's one of the reasons sometimes when patients cannot tolerate Clomid,
Yes.
right? So
Yeah.
we can have patients with significant headaches. The mood changes, like, you know, patients may feel really down. And that's something else that can be seen with PCOS. There's a higher, you know, risk of like depression in these patients. So these are reasons why maybe changing therapies from, you know, a pill to something like that, if they cannot tolerate, the injections are more tolerable,
Yeah,
definitely.
yeah.
Mhm.
And I see a great question coming through about egg freezing. Certainly patients with PCOS are great candidates to freeze eggs. We would go through the same process that we do for IVF, where we give you medication. It's the same hormone your brain makes every month, this FSH hormone that Dr. Mann mentioned, that stimulates your ovary. But we just have to give you a little bit more of it to get the estrogen levels up to grow those eggs. And then we can harvest those eggs and put them on ice and keep them there till you need them. So PCOS in no way precludes you from doing all of those sort of fertility procedures that are available. And in fact, a lot of people with PCOS tend to be higher responders and that they make a lot more eggs, which is really great for your
Right.
the outcome that we want.
Yeah. So then in those patients, to follow that also, we actually have a great way to reduce your chance of getting hyperstimulated, because those patients are at risk of developing ovarian hyperstimulation syndrome, which
Right.
you get, your ovaries are very large, and, you know, you can get fluid in your belly, which is not commonly, but we watch
Right.
and monitor you. But we can medication called Lupron, which actually substantially decreases, if not, it eliminates the risk of, like, you know, severe OHSS, but it
Yes.
substantially decreases
Yes.
your risk of getting very sick. And so
Yeah.
it's they're really, it is a manageable condition.
Yeah, yeah.
Mhm.
So, you know, it's I think that we do meet a lot of people that feel that maybe somebody suggested along the way that PCOS might be something going on, but it's so important to see an RE to really get the proper workup and address each of these pieces of, you know, your all the things you can do on your own to improve your metabolism and improve this condition, and all the testing that we might need, like we said, an insulin sensitizer, you know, that
Right.
you know, that is important in improving your insulin resistance problem, which will help everything and help you with cycles and be synergistic if you want to add it in the Clomid. So there's a lot to do, and you know, I've seen so many patients over time really just go from being so symptomatic and being so concerned to really so many improvements with
Yes.
easy things that they can do.
And you know, like
yeah.
for patients that are struggling with weight issues, and it's a significant problem, like if those patients that are, you know, morbidly obese, you know, and they're young, I mean, in those cases, sometimes it's better to focus on weight loss significantly and, you know, discuss with somebody about bariatric surgery.
Yes.
And we say this because we know that there's things that can be done that, you know, and can be done in more in a natural way, as you know, supposed to if you cannot do it anymore and it just doesn't work for anybody, bariatric surgery is an option to discuss as well.
Yeah. And you know, we could just go on and on and on because it's such an interesting thing, and it's something that's so common to see. It's so prevalent, and it presents in such different ways. So any of you out there that have questions or think it's something that could be going on for you, you know, come talk to us, because there's so much that we can do to make things better and make you feel in control and calm you down, that it's something that
that's
is
right,
totally manageable and that you will do fine with. But I know before we run out of time, because, you know, Instagram's just going to like cut us off. I wanted to make sure you guys know we're going to continue to do these because we're having so much fun with it. And, you know, what else do we have to do other than telemedicine? And I mean, I got to go cook dinner again for like, I feel like I just cooked dinner like 3 hours ago. Is it already like time for that? Like I've never cooked so much and cleaned so much. You have to get to it again. But next week we have Dr. Serena Chen and actually Allison Tybalt, who I had mentioned before, who's phenomenal.
Great. That's awesome.
Yeah, and there, so that's perfect as far as you guys that are, you know, in here today and interested in the nutritional diet aspect of this. Tune in next week because you know you're going to hear from her. And Allison's one of my favorite people. She's such an inspiration. One of my bar method teachers, and I miss class with her right now and can't wait for the studio to reopen. But we really enjoyed all these people that have been on and waving to us and saying hi. And we can't wait to see you guys in the office again soon and be face-to-face.
We will be with masks, unfortunately, in the office, but you know, it's nice to see each other, like your beautiful people and faces and everybody. We really miss, you know, all our patients.
We do. We do. Yeah. And we're here for you. So call us anytime or email us, and we are going to wrap it up, but stay safe and healthy, everybody. And Jess,
wash your
hands. So much for
don't touch your face.
That's right. Go make dinner unless
don't
you
be
great
6
takeout
feet
place.
away.
I wish I had more. All right, everybody, stay safe and healthy. And
bye.
We'll see you again soon.
See you soon.
All right.
Good one. Take care. Bye.